everyone. In this video, we're going to begin talking about respiratory physiology. So we actually could break down some of the components of physiology into respiration and ventilation. And there's really a couple more components to that. Some books and some ways of looking at it will include diffusion, and then also later on we'll talk a lot about perfusion and how perfusion is really important in order to ensure that the whole process is working. But for now, we're going to start with these two categories. Respiration can be broken down into external respiration, which basically is exchange of oxygen and carbon dioxide between fluids in the environment. So this is what's going to happen, actually in the lungs. And then internal respiration, which is basically exchange of oxygen and carbon dioxide between the fluids or the blood and the body cells, so the tissues where the oxygen is going, and the carbon dioxide is coming from those tissues as well. Ventilation can be broken down into pulmonary ventilation, which is basically air movement into and out of the lungs. And alveolar ventilation, which is air into and out of the alveoli. So in this video, we're going to focus more on ventilation, talk about the respiratory cycle, and the next video will focus a little bit more on the components of respiration. In order to thoroughly understand respiratory physiology, we have to consider some laws of physics or chemistry. So we're going to start with Boyle's law, which basically indicates that pressure and volume are inversely proportional. So the traditional way to write this equation would be P1 V1 equals P2 V2, but I'm going to write it this way because I'm really more interested in the conceptual idea than actually doing any math with this. So when we say pressure and volume are inversely proportional, we're really saying that if we increase volume of a particular space that a gas is occupying, then the pressure of that gas is going to go down. And conversely, if we decrease the volume of a space that a gas is occupying, the pressure will increase. And so the thing to consider about this relationship is that while we could say we could look at it from the perspective of what if we change the pressure, in the application of Boyle's law to breathing, we're only going to consider changing the volume and then changing the pressure as a result of changing the volume. So I think it's best if we just look at it from that perspective. Now, the other thing we want to consider with regard to gas exchange and gas movement is the pressure gradient. So we've talked before about things like concentration gradient and electrochemical gradient, but now we're going to introduce another concept, which would be the pressure gradient, which is what we consider when we're talking about gas movement. And so we'll say that air or gases move from an area of high pressure to an area of low pressure. So we're still moving down a gradient. It's just going to be a different type of gradient. Okay, so now let's get to the respiratory cycle. The respiratory cycle is one inhalation and one exhalation. So if we draw the lungs at rest, we'll just draw the diaphragm, and we'll say the lungs aren't moving any air at this point. So there's no air movement, and so that's going to be our starting point. Now, when we consider inhalation, we have to recall that the visceral and the parietal linings that surround the lung are going to play a significant role in allowing lung expansion or lung recoil. So the visceral lining is what surrounds the lung directly, and the parietal lining is what lines the cavity, and so the pleural cavity. And the two membranes are separated by a small amount of fluid. So we've mentioned already that the significance of this fluid allows for reduced friction and ease of movement and sliding, and that allows the lungs to expand without causing any sort of pain or discomfort or difficulty on the part of the body. But the other thing that's important is that because there's water or a fluid in between these two linings, it gives them a little bit of adherence to each other. And so if we think of the rib cage and the parietal lining being on the very inside, but somehow connected right to the muscles and the bones that make up the rib cage, as inhalation is going to occur, the rib cage is going to expand. It's going to take with it the parietal pleura, and because the parietal pleura is adjacent to the visceral pleura and separated only by a small amount of water, it's also going to take the visceral pleura with it, and so what we ultimately have is expansion of the inside of the lungs. We also are going to have diaphragmatic contraction, and so basically in order to produce inhalation, the diaphragm will contract, the rib cage expands, and then the result is we get an increase in volume in the lungs. And up to this point, the amount of gas that's in the lungs has not changed. So if we increase the volume, then by default, we're now decreasing the pressure inside of the lungs. So now what we've created is a pressure gradient. So atmospheric pressure outside is going to be a certain amount, and at rest it would be equivalent to what's actually inside of the lungs. But as we expand the lungs, we're now going to get a decrease in pressure, and so the pressure gradient that exists between the inside and the outside will actually draw the air in. So one important point about this particular ventilation model is that we refer to normal breathing as negative pressure ventilation. And that's because the pressure inside of the lungs is lower than the pressure outside. And this is the opposite. If we're ventilating somebody, we call that positive pressure ventilation, because we are actually generating a higher pressure by bagging someone or using a mechanical ventilator, and that higher pressure is going to overcome the atmospheric pressure that would be in the lungs at rest. So it just gives us the two opposite perspectives. But normal ventilation is negative pressure ventilation. So the air is going to flow into the lungs until we reach a point of equilibrium. So when the gradient is completely eliminated. So when the pressure inside the lungs is equivalent to the pressure outside the lungs, inhalation ceases, and then we'll move to the exhalation component of the respiratory cycle. So during exhalation, the diaphragm will relax, and so it's actually going to move sort of upward, and the rib cage is going to return to its original position as well. And so now what we're doing is we're decreasing the volume of the lungs, and by default that means that we're going to increase the pressure. And as the pressure increases, we now have a pressure gradient again, but in the reverse direction. Higher pressure inside the lungs, lower pressure in the atmosphere, and so naturally the air will flow out of the lungs down the gradient, and it will flow down the gradient until the gradient is eliminated, and then we come back to rest. So the respiratory cycle considers one ventilation. We also like to consider how much air is being exchanged each minute. So we'll use the equation for pulmonary ventilation, frequency, or which is also the rate. So this would be your respiratory rate, right? Normal is 12 to 20. And we'll multiply that times tidal volume. And tidal volume is basically the amount of air that's inhaled or exhaled, and really it would be the same amount in a single breath, and it's measured in milliliters. And we multiply those together, we'll get minute volume, and minute volume is the amount of air that is inhaled and exhaled, or we could say exchanged, in a single minute. So this is very similar to considering the equation for cardiac output. That's something that you're already familiar with. And so we'll just do a quick example, a little bit of math. So normal rate is 12 to 20, so we'll pick 12 breaths per minute. And then tidal volume is normally about 500 mLs for a healthy adult, and it could vary a little bit, but one thing to consider is that for patients who are overweight significantly or obese, the tidal volume for them is not going to be significantly greater because their lungs aren't going to be bigger. So we usually consider tidal volume in terms of ideal body weight, and so we could say that 500 would be a good starting point. So 500 mLs for one breath, and we multiply those together, we get about 6,000 mLs exchanged per minute, which is equivalent to about 6 liters. Now we also have to consider alveolar ventilation. So we mentioned earlier that alveolar ventilation considers how much air is actually being exchanged at the alveoli, and so we're going to take into consideration something called dead space. So this time we'll multiply frequency times tidal volume minus dead space, which is going to get us our alveolar ventilation. So there are actually two types of dead space. Anatomic dead space is what we'll consider here, and physiologic dead space is something we'll consider in another video. When we think of anatomic dead space, what we're really talking about is the air that's brought into the trachea and the bronchi. This is air that is taken in during the pulmonary ventilation, but this air is never going to have the opportunity to participate in gas exchange because it's not going to reach the alveoli. So 150 mLs or so is considered to be a normal dead space, anatomic dead space for a healthy person. So we could do the math again. 12 breaths per minute times 500 mLs minus 150 mLs is going to get us about 4,200 mLs per minute, or about 4.2 liters. Now I just want to mention quickly lung capacity. So lung capacity is actually, so the total amount of air that could fit into the lungs is about 6 liters. And I don't want this to be confusing. It's not the same 6 liters that is exchanged per minute. We're talking about just like after maximum inhalation, we can hold about 6 liters of air in our lungs, which is really, really significant, especially when we think about only exchanging about 500 mLs in a typical breath. So we know already that tidal volume is the amount of air that's exchanged during a normal ventilation. We said that's about 500 mLs. But it's important to consider some other values that may be of interest or may change in the presence of disease. So first, let's consider the inspiratory reserve volume. The inspiratory reserve volume refers to air that is inhaled above and beyond a normal inhalation. So if you were to think about just like a simple inhalation followed by a simple exhalation, and then inhale again, and before you exhale, take another breath, so kind of like repeat the inhalation part and inhale until you absolutely can't inhale anymore. And that is the inspiratory reserve volume, the amount after that normal inhalation that can also be added. And this could be as high as about 3,300 mL. So it's really a lot more than what's typically exchanged during a normal tidal volume. Next thing we'll consider is the expiratory reserve volume. This is kind of the opposite of the IRV. And so this is your normal tidal volume inhalation, normal tidal volume exhalation, and then before the next inhalation, you exhale as much as possible until you just can't exhale anymore, and that is the expiratory reserve volume. So the expiratory reserve volume can be about 1,000 mLs, so it's also significantly higher than the tidal volume. And so it's just interesting to note like how much more the lungs can exchange in a time of need above and beyond what's normally utilized for just sort of at-rest behavior. The combination of tidal volume plus inspiratory reserve volume plus expiratory reserve volume gets us our vital capacity. And the vital capacity basically is how much air can physically be exchanged in and out of the lungs. And we notice that even though, so the vital capacity could be like, so according to this math, about 4,800 mLs, but we also notice that the lungs are not going to be empty. Even after exhaling to the expiratory reserve volume capacity, we are still going to have a little bit of air in the lungs. And that is our residual volume, and that could be about 1,200 mLs. The thing that's important about the residual volume is if you think about blowing up a balloon, that first breath, just to get the balloon to sort of puff out a little bit and have a little bit of air in there, is the hardest one. And then after there's a little bit of air, it's much easier to fill the rest of the balloon to its capacity. And so the lungs work the same way. We could think of the alveoli, the little air sacs, as little balloons, and if we deflate them completely, it's very, very difficult to reinflate them. But if we leave them a tiny bit inflated all the time, then to fill them with more air is actually very easy. So just the basic physics of it, it's just a little bit unrealistic for the lungs to be completely empty of all of their air at any point. Even after maximum exhalation. So we're going to save a little bit just in case. So even if, you're huffing and puffing and running a marathon, or it's a patient who's really, really critically ill, unless the disease pathology affects the ability of the alveoli to be slightly inflated, we could say that the alveoli will have a little bit of air no matter what, and then what will vary maybe is how much air is being exchanged above and beyond that. All right, so that covers the respiratory cycle and a little bit of an overview of pulmonary and alveolar ventilation. And in our next video, we'll talk a little bit about gas exchange at the alveoli. Thanks for watching.